Hello and welcome to this video lecture on the different types of cardiomyopathies. First, let's talk about what cardiomyopathies are. They're basically diseases that are going to affect the myocardium, which is the heart muscle itself. And that term cardiomyopathy really comes from the Greek words from cardia, meaning heart, and mys, meaning muscle, meaning disease of the heart muscle. And our cardiomyopathies can be categorized into primary, which are going to be conditions isolated to the heart, and secondary, which occur due to systemic conditions. The causes of these cardiomyopathies are really going to vary, ranging from ischemia and hypertension to genetic mutations and autoimmune disorders. Interestingly, the heart is the only muscle in the body that never takes a break. It beats about 100,000 times a day. So it's a hard-working muscle. And let's talk about the different types of cardiomyopathies that can develop when maybe workload has changed or the structure of the heart has changed. So we can subdivide these into three main types. We have dilated cardiomyopathy, which you can see pictured over here, and that really results in weakened contractions and ventricular enlargement, in which it can progress into heart failure with a reduced ejection fraction. Then the other type is going to be our hypertrophic cardiomyopathy, which you can see pictured over here. And this is really characterized by the thickened heart walls that can then obstruct blood flow. And we may have arrhythmias arrive. And lastly, we have restrictive cardiomyopathy, in which we are going to have a change of tissue here, and the heart becomes stiff and struggles to fill properly. And this can result in diastolic dysfunction. Now, in some extreme cases, cardiomyopathy can cause the heart to grow over twice its normal size. Now let's go into specifics, and we will first discuss dilated cardiomyopathy. Like we said, we have various causes here, like ischemic heart disease, valvular disease, diabetes, renal failure, alcohol and drugs, infections, or maybe genetic factors. All in all, it's going to lead to an enlarged, weakened heart that will struggle to pump effectively. So this image here shows us how we have a dilation of that ventricle, and then that is going to obviously be more difficult to contract this ventricle properly, and that's what we call systolic dysfunction, and that could lead to heart failure. So this is going to cause symptoms such as breathlessness and swelling and fatigue, displaced apical pulse, and jugular venous distension. Our diagnosis is confirmed through imaging, such as a chest x-ray or echocardiogram, and our treatment is going to be managing that heart failure, and in severe cases, heart transplantations. Sometimes that's the only solution for a severe dilated cardiomyopathy, and over 3,500 heart transplants are performed worldwide every year. And just a fun fact that the longest surviving heart transplant patient lived over 37 years with a donor heart. And in conjunction, we also want to make sure we prevent dysrhythmias from taking place and trying to best manage other symptoms. Now let's talk about a hypertrophic cardiomyopathic heart, and that is the most common cause of sudden cardiac death in young athletes. So definitely something of concern. This usually has genetic mutations that affect the sarcomere proteins within our cardiac muscle. And so with that, we're going to have thickened heart walls that potentially block blood flow, and we have increasing arrhythmia risk. So patients may experience palpitations and fainting, and the diagnosis involves imaging and genetic testing. Our treatments would include medications, lifestyle changes, and in high-risk cases, we have defibrillator implantation or surgical interventions. And as we said, young athletes are at risk, so we want to have heart screenings that play a vital role within sports. And also, I forgot to mention that we can give mavacamten, which is a medication that treats this symptomatic obstructive hypertrophic cardiomyopathy in adults. So this is going to help inhibit cardiac myosin, which can improve cardiac function. And I wanted to move into a little bit more specifics in hypertensive versus valvular hypertrophic cardiomyopathy. Now, what's amazing is that the heart can actually remodel itself in response to long-term hypertension, like a muscle getting bigger whenever we're weight training or resistance training. But of course, this can be a dangerous consequence. So these two types of cardiomyopathies result from that heart working against some type of increased resistance. When we focus on the hypertensive forces that the heart has to take in order to pump the blood, that can lead to thickened walls like we see pictured over here. I like this view in particular because it's a cross section of the heart and you can compare that to the other ventricle. Whereas with our valvular type, then we're going to see some stenosis that typically takes place in the aortic valve, and similarly, it's going to cause excess strain on the heart. And both of these conditions are going to remain asymptomatic for years, but then it can lead to heart failure over time. Now, sometimes we can take a look at EKGs to notice some changes. It's often suggested by specific characteristics that we find on these EKGs showing our large negative T waves. And you can also see listed here are some other types of waves that we can look for in order to help diagnose this condition. Now let's move into our last type, which is restrictive cardiomyopathy. Now, the heart doesn't ever tire out. It keeps pumping, except for when we have restrictive cardiomyopathy. It is going to become stiffer and is going to have a harder time pumping. Now, hopefully it doesn't stop pumping completely, but we know that this becomes restrictive. As we said, you can see kind of pictured over here, we will have that heart muscle stiffen up. It makes it difficult for the blood to move and fill the ventricles properly. And it's often linked to systemic diseases like amyloidosis. And you can actually see that pictured down over here. And if you've never heard of cardiac amyloidosis, it is these deposits of protein amyloid, or actually maybe you've heard of this in something like Alzheimer's disease, where they get a buildup of amyloid plaques within the brain. So similar thing happening here, where we are going to get a depositing of the protein amyloid in the cardiac muscle, and it can also happen in surrounding tissues. An amyloid is a misfolded and insoluble protein that can be in the atria, the valves, or the ventricles. And so these deposits can cause that thickening in these different areas of the heart, and that can lead to decreased cardiac function. We can also have these deposits of amyloids in areas like the liver, the kidneys, the spleen, our adrenal glands, and our bones. So symptoms could be systemic venous congestion, in which we see this in right-sided heart failure, where we get that distended jugular vein, or that blood goes back through the superior and inferior vena cava and can cause an enlarged liver or an enlarged spleen. And to diagnose this, we can use an echocardiogram and do myocardial biopsy if needed. We can also treat this by treating the underlying condition and managing heart failure. So that is it for our cardiomyopathies. If you have any further questions, feel free to comment or reach out to me.